Welcome to today's presentation on extracorporeal membrane oxygenation, ECMO, in the intensive care unit, ICU. In this session, we will explore the vital role of ECMO as a life-saving intervention for critically ill patients. Let's delve into the details of ECMO and its applications in the ICU. ECMO, or extracorporeal membrane oxygenation, is a specialized technique used to provide temporary support to patients with severe respiratory or cardiac failure. It involves the use of a mechanical circuit outside the body to oxygenate the blood and remove carbon dioxide, essentially performing the functions of the heart and lungs. Indications for ECMO include life-threatening respiratory failure, such as severe acute respiratory distress syndrome, ARDS, refractory hypoxemia, or hypercapnia. It is also used in cases of severe cardiac failure, including cardiogenic shock or myocarditis, where conventional therapies have failed to provide adequate support. ECMO involves the insertion of cannulas into large blood vessels, typically the jugular or femoral vein and artery. Blood is drawn out of the body through the venous cannula, passed through an artificial membrane oxygenator that adds oxygen and removes carbon dioxide, and then returned to the patient's arterial system through the arterial cannula. This process provides oxygenation and supports cardiac output, allowing the patient's heart and lungs to rest and recover. There are two primary types of ECMO used in the ICU. The no-arterial ECMO, VAECMO, supports both cardiac and respiratory functions, providing oxygenation and circulatory support by bypassing both the heart and lungs. Venovenous ECMO, VVECMO, primarily supports respiratory function, providing oxygenation while allowing the heart to continue pumping blood. ECMO is a complex intervention that requires careful patient selection and management. Proper cannulation technique and site selection are crucial for optimal ECMO function and patient safety. Anticoagulation with heparin or alternative agents is typically used to prevent clotting in the circuit. Continuous monitoring of circuit function, oxygenation, and hemodynamics is essential. Patients are gradually weaned off ECMO support once their condition improves, and decannulation involves safely removing the ECMO cannulas. ECMO offers several advantages in critical care management. It provides temporary life-saving support for patients with severe respiratory or cardiac failure. By supporting the heart and lungs, ECMO allows time for recovery and reduces further damage. It offers excellent oxygenation and carbon dioxide removal, ensuring adequate tissue oxygenation. Additionally, ECMO can serve as a bridge to recovery, allowing time for the underlying condition to resolve, or as a bridge to heart or lung transplantation. While ECMO can be life-saving, it is not without risks and potential complications. Anticoagulation increases the risk of bleeding, requiring careful monitoring and management. The insertion sites for cannulas pose a risk of infection, necessitating strict aseptic techniques and vigilant monitoring. Circuit-related complications, such as clot formation, oxygenator dysfunction, or mechanical failure, can occur and require prompt intervention. In conclusion, ECMO is a life-saving intervention in the ICU, providing support to patients with severe respiratory or cardiac failure. It offers the potential for organ recovery, bridges to recovery or transplant, and optimizes oxygenation. However, careful patient selection, appropriate cannulation, diligent monitoring, and management of potential complications are crucial for successful ECMO outcomes. Thank you for your attention. We hope this overview of ECMO in the ICU has provided you with valuable insights into this remarkable intervention for critically ill patients.